Let me tell you about a man I know. 71 years old, retired, sharp-minded, still mowing his own lawn, still driving himself to Tuesday poker nights. His wife finally convinced him to go in for a physical he'd been putting off. The doctor looked him over and said everything seemed fine, then added 6 words that changed everything. Let's just run a few tests. 3 months later, that same man was recovering from a procedure he never needed, for a condition that would never have harmed him, dealing with complications that had nothing to do with why he walked in. The life he had before that appointment, the lawn, the poker, the independence, that version of his life was gone. This story isn't rare. It even has a name in the medical literature. My name is Dr. Richard Ben. I'm a physician specializing in cardiovascular health and aging, specifically how the body's circulatory system changes after 60 and what that means for how we make medical decisions. The pattern I keep seeing is this. People who felt perfectly fine walking into a routine appointment and came out the other side dealing with something they never had before the first test began. That pattern has a mechanism. It has a name. And once you understand it, you'll never sit in a doctor's office the same way again. Here's the number that should stop you cold. Studies estimate that between 15 and 25% of all medical procedures performed in the United States every year are unnecessary. But here's the part nobody talks about. That percentage climbs sharply after age 65. Not because older patients are sicker, because the risk to benefit math changes completely, and the medical system was not designed to do that math in a 15-minute appointment. There's a concept called the cascade effect. It works like this. One routine test finds a small abnormality. That abnormality triggers a follow-up scan. The scan leads to a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And someone who walked in feeling completely fine is now managing a medical situation they didn't have before they said yes to that first test. The cascade doesn't start with the surgery. It starts with the first test. Today, I'm going to walk you through 5 specific medical checkups I would personally reconsider after 65. Not because medicine is broken, because after 65, the risk to benefit math changes, and very few doctors are doing that math out loud with you. But first, one concept. Without it, nothing else I say today will fully land. The longevity lens. When you're 50, routine screening is one of the best investments you can make in your health. You find a problem early, treat it, and potentially buy yourself 30 more good years. The math is clean. The investment pays off. After 65, 3 things change that math fundamentally. First, many conditions that routine screening finds in adults over 65 will never actually cause harm. They grow slowly. They produce no symptoms. In many cases, you will outlive them. But once a result appears on a report, medicine doesn't have a leave it alone button. It has a treatment button, and that button gets pressed. Second, your body's tolerance for intervention is not what it was at 50. A surgery a 58-year-old bounces back from in 2 weeks can mean months of recovery for a 73-year-old, with complications, lost independence, and a quality of life that looks very different on the other side. Third, the cascade. One test, one abnormality, one chain of events that started from a place of feeling fine. Keep the longevity lens in mind through every item on this list. Number 5. Routine PSA. Prostate testing. After 70 in low-risk, asymptomatic men. I want to be precise here because this is easy to misread. I'm not saying prostate cancer isn't real. I'm not saying PSA testing has no value. I'm saying that for men over 70 with no symptoms, no family history, and no prior concerns, the data on routine PSA testing tells a story that most men in their doctor's office have never been told. A PSA test can detect a prostate cancer that is, biologically speaking, barely moving. A slow-growing tumor that left alone would never spread, never cause a symptom, and in a 71-year-old man would almost certainly never shorten his life. He would live with it, not from it. But the moment that result comes back elevated, medicine doesn't wait. Biopsies are ordered, specialists are referred, treatment options are presented. And for a man who is 71 and otherwise healthy, treatment for low-grade prostate cancer can mean radiation, hormone therapy, or surgery, each carrying real risks to continence, sexual function, energy, and overall quality of life. The American Cancer Society updated its guidance specifically because of this problem. For older men at average risk without symptoms, the risks of finding and treating a slow-moving cancer frequently outweigh the benefits. Raymond is 74, a retired electrician from Tulsa. Fit, active, no family history of prostate cancer, no urinary symptoms. His routine PSA came back slightly elevated. A biopsy confirmed a low-grade, slow-growing cancer. Gleason score 6, about as slow-moving as prostate cancer gets. His urologist recommended radiation. Raymond trusted that recommendation. Within 8 months, he was dealing with chronic fatigue that grounded his mornings, and urinary urgency that changed how he lived his days. When he sat down with me a year after treatment, the words he used were, "I felt better before they found it than I do now that they fixed it." That sentence is not rare. What to do instead? If you have urinary symptoms, hesitation, flow changes, waking at night, talk to your doctor. Those symptoms matter. If you have a strong family history, that changes the equation. But if you're 70 plus, asymptomatic, and average risk, the conversation shouldn't be, do we screen? It should be, what would we actually do if we found something? And is that treatment better for my life than watching it carefully? That question alone often changes everything. Number 4, routine bone density DEXA screening paired with automatic long-term medication. Osteoporosis is real. Falls are devastating in older adults. But there's a meaningful difference between questioning a test and questioning the automatic pipeline that often follows it. A DEXA scan detects bone density. If a result shows low bone density, many doctors move immediately to a class of medications called bisphosphonates: Fosamax, Boniva, Actonel. The message is simple: low bone density equals medication, and medication equals protection. Here's what that message leaves out. Long-term bisphosphonate use, particularly beyond 5 years, has been associated with a rare but serious condition called atypical femoral fractures. Stress fractures in the thigh bone, the bone you were trying to protect. These fractures can require surgery, and in some cases cause more disability than the fall they were meant to prevent. There's also a condition called osteonecrosis of the jaw, bone deterioration that is painful, slow to heal, and triggered by the very medication meant to strengthen your skeleton. Meanwhile, and this is the part that should be in every conversation about bone health, the single most effective intervention for reducing fractures in adults over 65 is not a medication. It is fall prevention, balance training. Studies on Tai Chi specifically show it reduces fall risk by close to 50%. Removing trip hazards from the home, installing grab bars in the bathroom, reviewing medications for dizziness as a side effect, getting vision checked annually. These interventions reduce your actual fracture risk more meaningfully than most pills, with 0 side effects. Gloria is 72, a former elementary school teacher from Phoenix. She had a DEXA scan after her annual physical and was told her bone density was below normal for her age. Her doctor prescribed a bisphosphonate that same day. Gloria came to me 3 years later with a persistent ache in her thigh that turned out to be an early atypical stress fracture. She had never fallen. She had no fracture history. She was taking medication to prevent a fracture, and that medication was what her bone was reacting to. What to ask? What is my actual fracture risk based on my full profile, not just the scan result? And can we compare what I'd get from medication versus a structured fall prevention program? Any good doctor should welcome that question. Number 3, routine cardiac stress testing without symptoms. This is the one that surprises people most because it sounds so responsible. Your doctor says, "You're 68, let's just make sure your heart is doing okay." You get on a treadmill, or they give you a medication that temporarily stresses your heart and monitor what happens. What could possibly be wrong with that? Here's the problem almost no one discusses in the appointment room. Cardiac stress tests in people without symptoms, no chest pain, no shortness of breath, no exertion-triggered dizziness, have false positive rates that can reach 40% in certain populations. In nearly half of cases, the test flags an abnormality when your heart is actually fine. But medicine cannot shrug at an abnormal result. That false alarm sends you to the next phase, a cardiac catheterization, a thin tube threaded through your blood vessels, through your wrist or groin, directly into your heart. Risks include bleeding, vessel damage, arrhythmia, and in rare cases, the catheterization itself can trigger the very heart event you were screened to prevent. And if the catheterization finds a partial blockage, which is extremely common in adults over 65, including many who will live decades more without a single cardiac event, you may receive a stent. Here's the part I want you to really hear. Multiple major clinical trials, including the ischemia trial, one of the largest of its kind, found that stenting in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. The stent did not outperform a 30-minute walk and the right medication, but it carried all the procedural risk and often years of mandatory blood thinners. The cascade looks like this: feeling fine, to routine stress test, to false positive, to catheterization, to stent, to blood thinners, to ongoing monitoring, to no statistical improvement in outcome. And it all started because someone said, let's just check. What to do instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during activity, the conversation with your doctor should not be about stress testing. It should be about optimizing your actual risk factors: blood pressure, cholesterol, blood sugar, activity, sleep. That's where the real cardiac gains live after 65, and none of them require a catheterization to access. Number 2, routine carotid artery ultrasound in asymptomatic patients. Almost nobody is talking about this one, and given what the data shows, that silence is one of the most consequential oversights in routine senior care today. A carotid artery ultrasound looks at the large blood vessels in your neck that carry blood to your brain. The logic sounds sound. Find a blockage before it causes a stroke. Surgically clear it out. Problem solved. The reality is far more complicated, and for people with no symptoms, far more dangerous than it sounds. The surgical procedure used to treat a carotid blockage, a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately after surgery. In older adults with other health conditions, that number is higher. The United States Preventive Services Task Force, the gold standard body that sets screening guidelines in this country, explicitly recommends against routine carotid artery ultrasound in adults with no symptoms. Their analysis is direct. In asymptomatic people, the risk of surgical intervention outweighs the likely benefit. Here's why. A large portion of adults over 65 have some degree of narrowing in their carotid arteries. That narrowing has often been there for years, stable, silent, not causing problems. When you screen for it routinely, you find it, and then a well-meaning surgeon recommends fixing it. But the surgery to clear a blockage that was never causing symptoms can dislodge a small piece of plaque that travels directly to the brain. The intervention causes the exact outcome it was meant to prevent. What to do instead? If you have no neurological symptoms, no sudden vision changes, no facial drooping, no arm weakness, no brief episodes of confusion or slurred speech, routine carotid screening is generally not recommended. Your energy should go toward managing the actual modifiable stroke drivers: blood pressure, the single biggest one, blood sugar, atrial fibrillation if that applies to you, and staying consistently active. If you do have any of those symptoms, even briefly, even if they resolved, that changes everything. Get evaluated immediately. That's not routine screening anymore. That's your body sending a signal that deserves an urgent response. Number 1. Routine colonoscopy after age 75 in low-risk asymptomatic adults. This is the one most people have never heard challenged, because colonoscopies have been so thoroughly endorsed for so long that questioning them, in the right context, feels almost counterintuitive. But the data for adults over 75 who have no symptoms, clean prior scopes, and no family history tells a different story than most people hear. The United States Preventive Services Task Force explicitly recommends against routine colonoscopy screening for average risk adults over 75. Their reasoning is not vague. The risks begin to outweigh the rewards, and those risks become very concrete when you understand what can go wrong. Bowel perforation, a literal tear in the colon, occurs in approximately 1 in every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, a colostomy, extended hospitalization, and a recovery that permanently changes independence and quality of life. That's not counting the preparation itself, the bowel prep liquid that clears the colon before the procedure, which in older adults can cause dangerous dehydration, electrolyte imbalances, and cardiac stress. There's also the sedation risk, which climbs with age. And returning to the longevity lens, the colon cancers most likely to be found in asymptomatic adults over 75 tend to grow slowly enough that in many cases they would never cause problems within that person's remaining lifetime. Margaret is 78, a retired school teacher from rural Ohio. She had 2 colonoscopies in her 50s and 60s, both completely clean. No polyps, no family history, no symptoms of any kind. Her new primary care doctor looked at her chart and said she was due for another one. Margaret asked questions. She was reassured it was routine. She went ahead. The prep hit her system hard. By the following morning, she was confused, weak, and barely able to stand. Her daughter took her to the emergency room before she ever reached the procedure room. Her electrolytes were critically low, and her heart was under strain from the dehydration. She spent 5 days in the hospital. She never had the colonoscopy. When Margaret called me after she was discharged, she said, "I felt better when I was overdue for that test than I did after trying to take it." What to do instead? Ask your doctor about non-invasive stool-based testing, the Cologuard test, or an annual FIT test. These can flag genuine warning signs without any procedural risk. And if you do have symptoms, blood in your stool, unexplained changes in bowel habits, persistent abdominal pain, that changes the equation entirely. Those symptoms require evaluation regardless of age. The 5 questions to bring to every appointment. Every time a doctor recommends a screening test, especially if you're over 65 and feeling well, have these 5 questions ready. Write them down, put them in your phone, bring them to every appointment. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to send you down a path of follow-up procedures, even when nothing is actually wrong. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? Don't let the conversation stop at, "we found something." Push it to, "and then what?" Question 3. What is the procedural risk of the treatment we would most likely pursue? Every procedure has a risk profile. You deserve to know it before the procedure, not after. Question 4. What happens if we monitor this instead of treating it immediately? For many conditions found in older adults, watchful waiting is a legitimate and often superior option. It is not giving up, it is doing the math correctly. Question 5. What is the most effective non-invasive approach for this condition? Because, as you've seen today, with bone health, heart health, and stroke prevention, lifestyle and medication frequently outperform procedural intervention with a fraction of the risk. Any physician who is genuinely in your corner will welcome those questions. They won't make you feel difficult for asking them. And if a doctor dismisses those questions or makes you feel like a problem patient for raising them, that is important information about whether that doctor is the right fit for you. Before your next appointment, whether it's next week or 3 months from now, write those 5 questions on a note card or put them in your phone right now. Bring that card into the appointment. You don't have to use all 5. You may only need 1. But having them with you changes how you show up in that room. And how you show up in that room changes what happens to your health. By the end of 30 days, 1 appointment, those 5 questions, you'll feel like a different kind of patient. Not a difficult one, a protected one. Someone who understands what the tests are for, what the follow-ups mean, and what to ask before the cascade begins.